first vaginal penetration, sexual or non-sexual, which is often seen in younger women. So anytime they try to use a tampon or they touch themselves, or they couldn't ride a bike when they were a kid because it was just too uncomfortable, chances are they have primary vestibulodynia. Secondary vestibulodynia, on the other hand, is a woman who has had pain-free intercourse, pleasurable intercourse, and all of a sudden it starts to hurt. And it either can be progressive or it can be really fast, but they reach a point where they can no longer have sex because of the vulvar pain. That's secondary vestibulodynia. Potential contributing factors were added 3 or 4 years ago, and I have them listed here. They're in alphabetical order, and I have the ones circled: the comorbidities, the genetics, the hormonal factors, inflammation, musculoskeletal, neurologic mechanisms, neuroproliferation, psychological factors, and structural defects are the things that now sit and you go around the opening of the introitus. Typically, that should cause no pain. But if it does, that's a positive test, and everything else, you don't have any of those other things. Just that pain, that's a positive diagnosis for vulvodynia. Now, we're going to leave that world, and we're going to go into the world of anatomy, which is my wheelhouse for sure. We talk a lot about the pelvic clock. From 12 o'clock at the clitoris, 6 o'clock at the perineum, at the perineal body, 3 o'clock and 9 o'clock on either side. Just for clarity, right? So this is the superficial pelvic floor muscles. I used this model when I did the workshop, and it really is one of the greatest teaching tools I've ever had. Superficial pelvic floor muscles almost form a triangle of support around the vaginal opening, continues almost in a figure-8 pattern to form the external anal sphincter, then comes back and attaches to the tip of the coccyx. If we get rid of that, which a lot of women in my office always wanted me to do, can't you just take that off? You come to the deep pelvic floor muscles. They're much bigger and broader. You can see from the inside, it's that sling of muscle on the inside, so that when it contracts, it literally pulls up and in. When the superficial pelvic floor muscles tighten, they just kind of close up the outside opening of the vagina, but not all the way. These are the guys that really do the majority of the work with pelvic floor muscle contractions. Very careful. So that's superficial pelvic floor. Now I go on to the deep pelvic floor. This is looking at it from the bottom up. This is looking from the top down. And again, you get a sense of that sling-like structure really forming basically the floor of our core, which is one of the functions of the pelvic floor muscles. The first that we talk about is it supports the pelvic organs. Pelvic organ prolapses are very pretty, so we really like those muscles to work well. Pelvic floor muscles also help control micturition and defecation because they contribute to the sphincters in the urethra and the rectum. They also contract and relax with orgasm, or maybe not, as we were told yesterday or the day before. And they truly are the base of the core support. Around with the abdominal muscles, a couple of muscles that run up on either side of the spine, they are the base of the core supports. They're really, really an incredible group of muscles. If we take a look from the medial aspect, this is the pelvic floor muscles coming in here. This is the vaginal opening of the rectum. The pelvic floor muscles really are broad and come all the way from either side of the pubic symphysis, all the way attaching back to the ischial spine. This is a really important muscle. Here, this is the obturator internus muscle that underlies the pelvic floor muscles, the deep pelvic floor muscles. I always say they're kind of like brothers. They can really irritate each other. There's tension in one and cause tension in the other, and vice versa. And also, you may hear a lot about piriformis syndrome. This is the piriformis muscle attaching to the sacrum and coming down. This is the coccygeus, which is the lowest muscle attaching onto the base of the sacrum and the coccyx, coming over to the ischial spine as well. Not considered part of the pelvic floor, but it's right there. If we add in the neurovascular systems, you can see there's a heck of a lot going on in that pelvis. You know, I again have this area circled because it's this is kind of like driving a car in India. There's things coming from every which direction and going, and nobody really, goes everywhere. So you see the lumbosacral nerve roots coming down into that area and going behind the ischial spine and the vasculature coming down and then really running all the way through that obturator interens muscle. So you might have a sense that if those muscles get tight, they might have some impact on what's happening in those neurovascular structures. So if we're going to take a look and see what happens with overactive superficial pelvic floor muscles, the areas show where that contraction happens. The muscles come in, they gently close the opening of the vagina. This, on the other hand, is the deep pelvic floor muscles, and as I said, when they contract, they pull up and lift the entire pelvic floor. This represents a line, and we talked about this in the workshop. Be very careful. If we have a plane across the ischial tuberosities, a normal functioning pelvic floor will have the perineal body just superior to that plane. With hypoactive or weak pelvic floor muscles, that perineal body is going to be below that line with a bigger opening of the vagina. However, if there's overactivity or hyperactivity, that pelvic floor muscle gets squeezed and pulls up and in, and that perineal body, you kind of have to look for it. You know, when you have a patient who lays down on your table and you're trying to figure out what's going on, and you can't see the opening of her vagina because it's being pulled up into the pelvis, chances are she has some pretty good pelvic floor muscle overactivity going on, pulling it up and in. When that does happen as well, the size of the vaginal opening decreases. So it's really, really common in women with vaginismus. And they say, I don't want you in there, I don't want you touching me, go away. We don't really know for sure whether or not the pelvic floor muscles live in that state with women with provoked vestibular, or if it only happens when there's somebody coming up to do something to touch the vulva. 2 studies done in Canada, they conflict with each other. One says that, oh no, the pelvic floor muscles are just reactive. The other suggests that the pelvic floor muscles stay in that hypertensive state. We really don't know. It's my guess as a practitioner that it's a little bit of both. This is how I, as a physical therapist, assess my patients. I refer to it as a modified Q-tip test because I'm going to use my finger to go inside to do further exam. So I'm going to start, and I'm going to go at 3 o'clock and wiggle my finger a little, 6 o'clock wiggle my finger a little, 9 o'clock and wiggle my finger there, and ask her what her pain is. 0 to 10, 0 is nothing, 10 is the worst pain ever. Where are you at each of those 3 points? And I record that. But I'm here to suggest to you that it's not just the pelvic floor muscles that are the problem. This is, I'm taking shots of this. This is from a paper that I published in 2010. We have visceral components all throughout the pelvis. You have the uterus with the fallopian tubes and the ovaries. You have the bladder, the urethra, the urachus coming up, and the ureters going up to the kidneys. You also have a lot of ligamentous structures. My heavens, there's so much ligamentous structures in here that hold up and support that growing uterus when there's a fetus inside, that helps support the uterus, the bladder, the rectum. That huge fascial component is there as well. We have joints. We have the pubic symphysis joint in the front, the 2 sacroiliac joints in the back. That's the bony structure that holds it all together. And last but not least, we have the pelvic floor muscles most inferiorly and all the way down on the outside. So, what the heck do physical therapists do? I've had that question asked to me over the years. I grew up with the ISSD, the International Society for the Study of Vulvovaginal Diseases, and my first meeting was in 1997, and they thought I was really crazy. They said to me, "You do what? Where?" But it's true. There are a lot of us, and we've come a long way. This is a study that I did, just a questionnaire of women's health physios in the United States, because I wanted to know what the PTs were doing for women with provoked vestibular. And I'll not go through the whole thing, but what I would like you to see is that assessment modalities, these 7 modalities were used by more than 70%. Nearly 70% used these 7 treatment modalities, and that was women's health PTs with 11 years of experience, 6 of those treating women with vulvodynia, at least. A couple of years later, I did an international study because I just wanted to see if what was going on around the world was the same. And we had 100 PTs from 9 different countries, and more than 60% of those used 21 specific assessment tools. This is 3 years later. And more than 70% agreed on the use of 16 treatment options. So we just needed to know that we're all kind of doing the same things. We don't really know what we're all doing, but we all do the same things. The internal pelvic exams, I was really interested to see more of what people were doing. I won't go through all of that because it's crazy stuff. This is a systematic review on physical therapy for women with chronic pelvic pain. It was just published last month. It included 38 RCTs, which had 2,168 women. And basically what they searched, what they wanted to search was multimodal physical therapy, which is physical therapy with all those things that we do, psychological approaches, and acupuncture or other tissue-based monotherapy. So one like an electrical stimulation or something that's only one thing. The groups within that chronic pelvic pain included provoked vestibulodynia, women with dyspareunia, GPPP, PPPD, that done a new name for genital pelvic pain and penetration disorder, and gynecological pain. So it depends on who diagnoses the problem with chronic pelvic pain as to what it is, but they decided that with this, they knew that they had what they needed to talk about these studies, to talk about these results. Basically what they found was that meta-analysis of multimodal physical therapy resulted in lower pain intensities compared to inner or non-conservative treatments, both in short and intermediate terms. I learned from the women who had been so gracious to come and trust me with their care. It's 5 exercises aimed at easing pain prior to any type of vaginal penetration. This is a video, so if we could have this played, please. Do I have to do it up here? Can I do it up here? No. If there's video, can you hear it? Can you turn the sound on? This has to be right here. Oh, okay, that's my fault. I didn't take it. Dysfunction is second. Can we go back? Let's go back. Okay. I'm going to have to change it. You know what? Will you go ahead and change it now since you're here? Because this is the wrong one. So this one, let me just write down these. No, this is the one. Okay. No, this is not the one. I'm sorry, guys. This is what happens for those of you who are as old as I am. Remember when we had to use slides and you had to take pictures and then you had to order slides and you couldn't change them? And now we can change things at the last minute, and that's, of course, what I did this morning. So we need to get a different version of the talk. So I need a different version of this talk. What's in the zip drive? Can you go back to the zip drive? Okay, we'll watch the video first, and then I need to go back to the zip drive.
Though pelvic floor muscle dysfunction appears to be a primary driver of chronic lumbar pain, it is possible that the muscular dysfunction is secondary to abnormal tension in the surrounding abdominal and pelvic viscera, fascia, and muscle. Together, these abnormal physical findings make internal assessment, whether digital or with the speculum, painful, difficult at best, or oftentimes impossible. This video will introduce 5 simple patient activities that can be used prior to intravaginal examination. Those activities include deep lateral diaphragmatic breathing, self-stretching of the lower abdominal wall, bilateral stretching of the deep hip muscles, active bridging, and active pelvic floor muscle mobilization. 3 women with chronic vulvar pain, Kathy, Holly, and Lisa, were assessed prior to and following instruction and completion of these activities. 0 to 10. 0 is no pain, 10 is the worst pain ever. What does this feel like? Give me a number. 6 or 7. And this is right at the bottom. This is right at the posterior facet. I'm going to turn my finger to the left, 3 o'clock, and give me a number there. 10. And over here on the right, 9, 10. So not very good today. Using gentle digital palpation prior to those activities, each woman's vulvar pain was assessed at 3, 6, and 9 o'clock at the introitus. My assessing digit remained at the posterior fourchette throughout the completion of the activities, allowing me to reassess changes as they occurred. Now, I want you to put your hands on either side of your rib cage for me. Go down. And I want you to put a little bit of pressure. And I want you to take a really deep breath for me. As you do that, I want you to push your rib cage out. Wonderful. I don't want your belly to go up. I don't want your chest to go up. You get to the knee, go ahead and breathe out. I want you to do this 5 or 6 times for me. And as you do that, your diaphragm goes down to pull you down. And physiologically, as that happens, as it transfers pressure down from the respiratory diaphragm all the way down to where my finger is. My finger's still where it was. I'm going to move it just a little bit. I'm still at that 6 o'clock spot. How does it feel now? Can you give me a number? 7. How about here on the left side? 8. How about here on the right side? 7. Yeah. Now I want you to take your hands below your belly button, and I'm going to have you scoop in and pull up for me. And I want you to hold it there. There's a ligament on the back side of the abdominal wall that goes down behind the pubic bone into the pelvis. And relax it again. And I want you to do that again. And lift and pull. Clinically, what seems to happen is that bit of fascial pull releases tension all the way down through the bladder, through the urethra, and through the pelvic floor muscles. Let's go back to 6 o'clock. How does it feel there now? Give me a number.
It's barely any pain.
Barely any pain. How about here on the left?
2.
And here on the right?
3.
Okay. So now I'm going to have you stretch your hip muscles. I want you to bring this right knee and take it up to your left shoulder, grab hold of it, and give it a good stretch. There are 5 deep rotators that lie right adjacent to the pelvic floor muscles. I found clinically that a stretch of these muscles really help to relax pelvic floor muscle tension. So bring this knee up to the opposite shoulder and back down again. I'm at 6 o'clock again. Give me a number.
3.
3. How about here on the left?
4.
And here on the right?
3 or 4.
3 or 4. Okay. Now I'm going to keep my finger here back at 6 o'clock again. And I want you to lift your hips up towards the ceiling. Go all the way up, and I want you to hold it for 10 counts. This is an extensor activity, trunk extension, hip extension. All of those muscles tighten to hold. Oftentimes the adductors will squeeze. Pelvic floor is such a frog where it goes along and it holds tight too. After 10 seconds, you come down and relax all of those muscles. And now give me a number at 6, 2, and at 3, 4, and at 9, 2. Now we're going to do pelvic mobilization. I just want you to pull your pelvic floor muscles in like you're holding back gas and pee. Squeeze and hold for 5. 1, 2, 3, 4, 5, and let go all the way down. And then 5 minutes. 2, 3, 4, 5, and let go. Now I'm back at 6 o'clock. How's it feel?
No pain.
How about here on the left side?
None.
And over here on the right side?
None.
Fantastic. At 6, 2, and at 3, 1, and at 9, 2. At 6 o'clock, how does it feel here now?
2.
At 2, how about over here?
2.
And over here.
2, 3.
You feel like you have any more space down there?
Yeah, it feels looser.
Feels looser and more relaxed, less burning.
Yeah.
Wonderful. When assessing women with chronic vulvar pain, please consider using these strategies to decrease tissue tension, reduce anxiety, and lessen palpated vulvar pain prior to performing intravaginal examinations. Our internal assessment should not cause more pain. Rather, we should start by giving women hope that they are not crazy, that this pain is not all in their heads, and that there may possibly be some very simple things that they can do to begin to help themselves regain control of their bodies. Thank you for your attention.
Could you come get this different version out, please? This is not If you could get that, if you could get what's on the zip drive up loud, I should. No, I just need a different. I need something else. We took the long one, the long copy. I told you the long one. You understand? This is not the right presentation. I need another one. So that it's on here. Can you go back to that? What else is on this set?
खुर्ची देऊ का खुर्ची देऊ का हां
Okay, that's good.
You go.
My apologies. Yeah, I didn't get the light. Yeah, I updated it. Can you get me back to the video, please? Oh. It's not proud of it. Okay, so you might say, how does that work? How do those exercises make a difference? Again, those are not physical therapy treatment. Those are something that women can do to help themselves. Before they put in a tampon, before they have a physical exam, before they use a sex toy, before they try to have sex, to try to lessen tension. They can also be used as exercise twice a day, working their way up to doing the pelvic floor muscle exercises for 5 minutes. And I'm going to suggest to you from a functional perspective, because that's how I work, that it matters because there are a lot of possible confounders that can impact the pelvis, the structures within the pelvis, and the pelvic floor muscles themselves. And that's where I really found we need to pay attention to the whole body. I know that's kind of a silly concept, but that's what happens. We need to know if there's a biomechanical impact somewhere, anywhere in the body that could be causing problems within the pelvis. We talked about those external hip rotors, the rotators, those 5 little deep rotators underneath the piriformis muscles that externally rotate the hip. The giant psoas muscle in the front, the 2 big hip flexors can be a really problem with the pelvic floor because they come right down, actually right close to where the pelvic floor muscles attach. This is the viscera. This is something that I do that not a lot of physios, and even in my own country, do. It's paying attention to what's happening in the gut. Because if you can imagine having IBS, what happens to your gut and the tension in your gut? Or if you have painful bladder syndrome, what happens with your bladder and your urethra? You have endometriosis, you have low back pain, but this is particularly the viscera. Any of this tension in the viscera, tension in any of these organs, can contribute to what's going on. In the video, you heard me talk about the urachus. The urachus is a fascial structure that comes down from the umbilicus, down from the falciform ligament, which supports the liver, goes laterally on either side, down all the way into that green notch, into that ischial spine, and the middle one comes and attaches to the top of the bladder. So that urachus pole actually puts fascial tension, fascial stress, and can release tension all the way down into the pelvic floor muscles as well as in the bladder and the urethra. Here you see a cross section, and you can see where the 3 prongs, middle one coming down into the bladder, and the 2 lateral ones go down and fascially attach and support the urethra and the bladder as it comes all the way down into that ischial spine. This was that diaphragmatic input. When you take a breath in, when you inhale, the respiratory diaphragm contracts. When it contracts, the pelvic floor muscle relaxes. When you exhale, that diaphragm comes up and the pelvic floor muscles come up with it. So if you're trying to teach someone how to use their pelvic floor properly, you'll have them take a really deep breath, and as they blow out, they pull in their pelvic floor muscles. Just like we blow out with any kind of muscle exertion, it's the same kind of thing. We're not going to do that. So the dance of the diaphragm is what I just said. Inhalation transfers pressure all the way down through that viscera that I just showed you to help relax and calm the pelvic floor muscles. This is that 3, 6, and 9 o'clock that you saw in the video. The 3, 5 things, the breathe, the stretch, the mobilize are the things that I think really help people. I also have patient exercise sheets that I have very fortunately have sent around the world. If anyone is interested, you have my contact information. Also, the video is on my YouTube page. It's open access. It's on my YouTube channel. You can find it there. So if we're going to continue with the exam, what am I going to do? I really want to take a look at all of these muscles in addition to the pelvic floor muscles. I want to see what's going on at the obturator internus, and I do that digitally up on the side. I can assess the pelvic floor muscles digitally going into the vagina on either side. However, if I want to take a look and see what the organs are doing, as I take my finger in to do my assessment, I do my digital, my assessment of the opening pain, I go inside and I immediately turn my hand over because at 12 o'clock is the urethra. If you come into that urethra and it just feels like a mound of tissue, that's a normal urethra. However, if you come in there and you come on it and you kind of roll on it, it almost feels like a pencil or a straw now. And your patient may say, "Oh, I don't like that. That burns, that hurts, that makes me feel like I need to go to the bathroom." That's abnormal tension in those longitudinal and circumferential muscles. That's not normal. If I go in and I find that, I'll also check the fascia, the periurethral fascia, on either side of the urethra to see what's happening there, to see if that could be contributing to some pain. I'll slide my finger in just a little bit further, and I come to the bladder, which is at the end of the urethra. If the bladder feels like a cotton ball and there's no tension there, you really can't palpate it at all, that's a normal bladder. However, if you go up in there and you say, "Ooh, that hurts, that burns, I don't like that at all," and you can really palpate it, that's abnormal detrusor tension. That's abnormal detrusor tension. Again, all of which, the urethra, the periurethral fascia, the bladder, can all contribute to make the pelvic floor muscles say, "Ugh, I don't like this, I'm going to hold tight because of it." There's a nifty little area on the back of the bladder called the bladder trigone, where the urethra comes up and the ureters come down on either side. It's really highly densely nerve innervated. I oftentimes will use that point because I've had so many questions after the workshop. It was just glorious. One of the things that I can do is come up to that spot and just come to that spot with my finger and take my hand on the outside, just above the pubic symphysis, just over the bladder, and just hold it there. I'm not putting pressure. I'm not doing anything. Basically, what I'm doing is bringing the brain to the urethra and bladder through those muscles, through those nerve endings. Oftentimes, it helps to really calm pelvic floor, bladder, and urethral tension. I'm also interested to know what the uterus does. Uterus hangs on the broad ligaments. It should swing in the breeze. We should be able to mobilize it right to left and anterior to posterior. I turn my finger over, it's the rectum, and the rectum is just like the urethra. If it's soft, it's normal. If it causes tension, pain, discomfort, it's not normal and it needs to be addressed. So I want to move on now from that. This is a bit of a study that I've been working on with the Lioness. Lioness is actually a consumer product. They call it the Smart Vibrator. It went to market in 2017, and they've sold now, I'm sure, close to 20,000. And they have records. Everyone who uses it, their records go to their anonymous list, their buckets, their iCloud, their server. And they have over 2,000 anonymous sessions. Basically what it is, and a number of you came up and saw it, is it's an intervaginal biofeedback. PTs have used biofeedback since the 80s for looking at pelvic floor muscle function, in particular with incontinence. It's that same technology. It has two sensors that measure the pressure of the pelvic floor muscles as they squeeze in and as they let go. It also has a clitoral vibrator. This doesn't vibrate, just this vibrates. It's Bluetooth. You have an app on your phone. You put it in. You watch your orgasm, you watch your arousal, and you can then go back and look at your orgasm on your phone, which I thought was pretty silly when we first decided to do it, but it's pretty darn cool. So we used it, and we looked at a number of, we just had random samples from people who suggested we could use theirs. We wanted to know if it could really do what we wanted it to do, and that's if it really was a good enough biofeedback unit to tell us what the pelvic floor muscles were doing. This is a study that was published in 1985 by Bolin, one of the only studies. These are biofeedback graphs. So this is when the pelvic floor muscle is calm. This is when the pelvic floor muscle, when they're masturbating, when they're stimulating the clitoris with their finger. This is actually vaginal and rectal, but we're going to stay just here. This is the orgasm, where the pelvic floor muscles go, oh, 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 oh. And this is the relaxation following the orgasm. This is what we were looking at in our study. We want to look at the average pelvic floor muscle resting tone. We wanted to look at time to orgasm, the duration of the orgasm, maximum orgasmic force, and pelvic floor muscle recovery tone. This, again, is when the unit goes in, it spikes up a little bit, but with somebody laying down with the biofeedback in, that's what a resting pelvic floor muscle looks like. However, if you turn the vibrator on, this is what happens to the pelvic floor muscles as you start to stimulate the clitoris. A little bit of vibration on the clitoris and it goes crazy. It really starts to jump around. But remember, this is at rest. This is all pelvic floor muscle contracting and relaxing, and these red dots stipulate where the orgasm happens, and then this is the orgasm here, and then the pelvic floor muscles taper off and relax. So we did find out that it works. It does what it's supposed to do. Great variability of pelvic floor muscle activity, normal and arousal, no normal arousal or organic patterns. Really to say, there's really no such thing as a normal orgasm, so let's not even talk about you having a normal orgasm. This is our ongoing study where we asked them to put the biofeedback in, and then I asked them to do 5 quick contractions and then let go and rest, and then squeeze and hold for 5 counts and then rest. And then turn the clitoral vibrator on until the orgasm happened. Here, they've then upgraded the software. This is the perceived orgasm, so that as the woman is going through this process with the lioness in, she can press a button that says, this is when my orgasm is starting, and this is when my orgasm is ending. Because we really want to see if Bowen's work really was the case. Interestingly, this is, in that study, this is 5 sessions from the same woman. You can see very different patterns, which is really quite interesting to me. Sometimes in this one, the algorithm said this was the orgasm. The person said this was the orgasm. So we still have a lot of work to do with this. This is just really preliminary. So this is another study that possibly might happen. A lot of you were here and saw this. This is the FemFit. This is made in New Zealand. It too is a pressure biofeedback machine, but you see it's much different than the big bulky Lioness. It's also Bluetooth, but it has 8 pressure sensors. It's able to measure pelvic muscle activity from the superficial pelvic floor all the way up to the inter-abdominal pressure. It's actually a trainer for incontinence. It too has an app where you make the birds fly, or you pop the clouds, or whatever it is. But again, it's really quite interesting for us to look at with arousal and orgasm, because you can see all of the channels. The different colors are all the channels. Obviously, this is clitoral vibration, this is the vibrator. This is the orgasm. The advantage to this is it's going to tell us exactly where in the pelvis, where in the pelvic floor muscles the orgasm is going to happen. It appears that it's that green. The green pattern is the one that contracted the most, and that's right in the middle of where that sits in the pelvic floor. So I had a conversation. How much time do I have? Because I don't even know what time it started. I guess messed up. How much time do we have left?
5 minutes.
5 minutes. Oh God. Okay, we're going to go as far as we got, and then we'll stop. Vibrators. What can vibrators do? And I think this may be really helpful for you guys. They've been used. Vibrators have been used to show improved sexual function and pelvic floor health. However, there are few studies looking at overall genital, urinary, and mental health. I'm not going to go through all of this, but it's 79 patients, 79 participants, 53 years old. And basically, their sexual function is significantly improved over time. The rate of bothersome of pelvic organ prolapse and pain scores significantly decreased. And the rates of incontinence decreased, although it was not significantly significant. This is using a vibrator, a bullet vibrator, externally for 5 to 10 minutes, 3 to 5 times a week, externally for 3 months. There's no arousal, there's no orgasm, there's no pleasure. That's not what it's for. It's really, really amazing. What they found was vibrator use was associated with improved sexual function in those who had partners, genital urinary, and mental health. So I put this out to you guys because I think it could really make, it may be a tool that you can use with women with vaginismus who aren't interested in anything internal. They don't want to have anything touched. They don't want to have an assessment. That may help make a difference. Dilators. You guys have seen the dilators. You were here, they were here. You're able to pick them up and hold them. This is a set from, obviously from the United States. They're silicone. They go from eensy weensy teeny tiny to it's stuck to the bone. It's a large margin. Okay, and I may end with using dilators, because somebody talked about using dilators, and I found, and you hear this any number of times, that, well, I got up to this one, and I could do it, and there was no pain, I could put it in or take it out, but when I go to have sex, it's just not the same. And I'll suggest you, if you use dilators, if you'll start with the smallest one that they can insert, contract their pelvic floor muscles around and relax, and take out with no pain, then you need to go to the next size. When you get to this size, if you put it in, you contract and relax around it, and you take it out, and there's a pain of about maybe 3, no more than 4, that's the one you stick with. You don't just tell her to put it in her vagina and leave it there for 20 minutes when it hurts like all bloody heck, because that's not helpful. If you put it in, and she contracts and relaxes around it, and uses the quick twitches and the slow twitches, until she does that up to 5 minutes at night before she goes to bed. When it gets to the point that she can put it in, take it out, put it in, contract and relax around it, and go to the next one, then she's moving up. The reason for that, in my mind, is that's neuroregulation. We're repatterning her pathways so that she knows that when something comes inside, she can contract and relax, and it doesn't hurt as much. Last I heard, penile penetration is movement, it's not still. That teaches her that when something comes in, when she contracts, which is what she wants to do, if she'll just let go, it'll feel better. So I find when I did use dilators, that's what I did. This is the Onetta, the thumper bumper, and this is the right slide, thank you, I was wrong again. The thumper bumper, it's these lovely little rings that you can use 1, 2, 3, or 4 of on the penis to prevent deep penetration. If you have someone who has pain with deep penetration, this allows however much penetration you want. You can take it off, you can have 3, you can take it off, you can have 2. But it's a really neat little tool that has helped a lot of women as well. Okay, we're not going to go into this because I'm almost finished. Sexual desire, arousal, and pleasure really are in our brainstem. They're our native, innate rights. We know that this is a lot of our women. This is every woman who came into my office. It's not just about the physical function. It's about her entire body, her history, everything that has gotten her to where she is today. I'm not going to go on with that. But I'm going to suggest that maybe we've all fallen short. If we're able to get rid of the pain in these women, again, I'm referring to my women with vulvodynia, we can get rid of the pain. Physical therapy is pretty good at it. Psychology is pretty fair. And surgery is pretty good, where they just cut the skin off, and we'll talk about that. But we know that women, even if you get rid of the pain, still don't reach the same sexual function as their non-pain peers. So we need to do something more. Maybe it's not just us, maybe it's the women themselves. Maybe they have no idea what to do. If they've never had pain-free sex, they're totally clueless. And if they've had pain-free sex, they may have blocked it out of pain-free sex, they may have blocked it out of their minds. So I really want to suggest that maybe the problem is that women don't know what they don't know. But when they can't have an orgasm, we know it's my fault. I'm broken. I'm not normal. And I don't really care because I didn't like having sex anyway. I don't ever have to have it ever again in my life. So we can continue with the traditional approach, looking a lot. We know a lot about the brain and how it impacts. We had a great lecture today on neurohormones. And Beverly was Rosemary Bassan's model of female sexuality. Or perhaps we can change and add in a little more function. We can talk a little bit more about the clitoris. Yeah, I do have all pictures around it. The clitoris is a really nifty little organ. It's not just a baby penis. Another time we can talk about clitoral function and clitoral anatomy. So my takeaway messages for this talk are the same as they were for the workshop, because this is what I'm really passionate about. Women around the world are suffering with chronic vulvar pain and sexual dysfunction, so often in silence. How many? Nobody knows. Millions and millions, because it's not diagnosed. Women don't talk about it. It's misdiagnosed. It's mistreated. They desperately need our understanding, compassion, and help. There are any number of ways leading to pain and dysfunction, including trauma and anxiety, all the way back, maybe not just back to when they were babies, but maybe back to when they were in utero, and maybe even further back than that. That does not mean that the pain's all in their heads, because we know that that trauma can live anywhere in their body. Perhaps we all need to consider adding discussion related to foreplay and pleasure, which I didn't talk about in this talk. Foreplay and pleasure are key, as well as really liking who you're going to bed with. We have a lot of knots to untangle before the flowers can bloom. Thank you very much for your time. This, by the way, is the book that I've co-authored. It's The Present Prescription, A Surprising Approach to Healing Sexual Pain. It's on Amazon, if anybody's interested. But this is my contact. I do not have my phone number up there. healthyexpg@gmail is my email address, and my website is departmentofphysicaltherapy.net. Thank you so much for your time and attention. I really appreciate it.
Thank you so much, ma'am. Thank you all. Any questions?
Yeah, now.
There's a little time. No, hold on, sir. We are asking for questions.
Oh,
No questions or no questions?
no questions.
No questions?
No questions.
Great.
Let me grab all my stuff. Yeah. Oh. I'm sorry, I was on my toes. Oh, thank you. Thank you so much. Thank you. Yes, thank you. Yes. Here. Thank you.
This was a giant Master oration. Thank you very much. You discussed almost everything in great details, and she emphasized on foreplay. According to her, foreplay to sex is like
24/7.
warm up to exercise.
That's exactly
Easy to omit but crucial for good results.
That's exactly right.
Anyway,
I
hand over the mic to Chairman
I'm sorry.
Venkata Ramana.
I have my DPT.
My friends, you all know that this oration is because of our Saroj Gumaste, Secretary and long associate of CSEPI. She installed this oration in memory of her husband. So that, now this year, Hartman has spoken about sexual pain disorders, aptly suited to that oration, and done excellent job and nice.
Thank you very much. I appreciate it.
I request the Harshit madam to
I request Venkatramana sir to hand over Dr. Tharija's trophy, which we missed giving him yesterday. And I request D. Hartman madam for joint, a small. Yeah. It's okay, no problem.
next session, please.
Next session.
Hello.
Session in charge to declare the next session and next chairpersons. The chairperson बुला रहे हैं।
Next session is on surgical precision for sexual function. May I invite chairperson for the next session, Dr. Kembavi Srinivas. He's professor.